All right, I think we can get started. I want to welcome everybody back to the Medical Biochemical Genetics Clinical Core Seminar Series. The date is October 2nd, 2020, and we're happy to welcome Dr. Hilary Vernon, MD, PhD from Johns Hopkins, and Kennedy Krieger. She's going to be talking to us today about peroxisomal disorders. Next week, we're going to have Dr. Austin Larson from University of Colorado here talking about glycosylation disorders and starting out to talk about clinical presentations of mitochondrial disorders. And just a couple bits of housekeeping. Again, make sure everybody's muted appropriately. We're still in conversation with the ACMG to talk about housing these lectures on their site. I think we got bumped to their October meeting for discussion with the board. We also, in the interim, have been talking with the SIMD, who's interested in putting the lectures on their site. So it may be available in 2 different places. I'll keep y'all posted on that. Otherwise, until then, it's available by Dropbox, as we were reminded last week. Make sure that you download the whole, download the presentation so you get the whole presentation instead of just 60 minutes of it. Again, as before, any questions that you have during Dr. Vernon's presentation, if you can send them to me, either the question or your name through chat, and we'll prioritize based on fellows. Anybody's welcome to ask questions, though, and we can have some open discussion at the end if there's not too many questions. So without further ado, I just want to thank Dr. Vernon for being here, and I'll give the floor to you.
Thanks a lot. And hello to everybody across the country. I am happy to talk to you about disorders of the peroxisome. And just to know, I'm not keeping an eye on the chat. So if questions come up through the chat, I'm not intentionally ignoring you. I'm not looking at it, but we'll get to everything at the end. So to cover some of the major pathways of the peroxisome, obviously we can't talk about everything that's going on in this multifunctional organelle. We will be walking through several enzymatic pathways, including that of fatty acid oxidation, which includes oxidation of the very long chain fatty acids within the peroxisome, vitanic acid and pristanic acid. We'll also be touching a little bit upon bile acid synthesis, plasmalogen synthesis, lysine catabolism. Within the peroxisome, there are also steps involved in DHA synthesis and cholesterol synthesis, which we won't be discussing today. A little bit about glyoxylate detoxification, D-amino acid oxidation, and just to sort of touch upon catalase, which doesn't have much of a clinical significance, but is important for hydrogen peroxide detoxification and really important for in situ imaging of peroxisomes. So to hit upon the really major concepts in peroxisomal protein import, there are 2 major peroxisome targeting signals that really separate the classes of peroxisomal proteins based on what introduces them to the peroxisome. So looking first here are the PTS1 proteins, and these are the majority of the peroxisomal matrix proteins, which are recognized by the PEX5S receptor, which then targets to the docking site of the peroxisome. So the PTS1 proteins have a C-terminal targeting signal. Again, most of the matrix proteins have the PTS1 signal, and as I mentioned, the receptor is PEX5. There are a handful of PTS2 proteins, there's 3 of them, that are recognized by this, by PEX7 and assisted by the PEX5L isoform to target, the PTS proteins to the docking site of the peroxisome. This actually has an N-terminal targeting signal, and the PTS2 signal is only located on 3 enzymes, a thiolase, which in and of itself doesn't have clinical significance because there's another thiolase within the peroxisome that can compensate for it. The phynyl-CoA hydroxylase, which we're going to talk about, and AGPS, which is important for plasmalogen synthesis. As we talked about, the receptor is PEX7, and what happens is these receptors will dock these proteins on PEX14 and PEX13. Then the receptor and ligand dissociation will occur. The ligand translocates and the receptor is recycled. So we're going to talk through now peroxisomal beta oxidation. And this involves, we're going to talk through very long chain fatty acid oxidation here. And these are carbon chains of greater than 22 carbons in length. They're activated by an acyl-CoA synthetase. They're then oxidized, undergo processing through the D bifunctional protein, which has 2 steps. And then a thiolase occurs to separate off the acyl-CoA groups. And then when we get down to carbon length of 16, the rest of the beta oxidation occurs in the mitochondria. But other substrates for peroxisomal beta oxidation include bile acids, some prostaglandins, leukotrienes, some xenobiotics, dicarboxylic acids, and some polyunsaturated fatty acids. And I just wanted to highlight that because we really tend to think of peroxisomal beta oxidation in terms of very long chain fatty acids. But of course, there are multiple other molecules that go through this pathway that are important both for diagnosis as well as treatment of disease. So just to talk a little bit more closely through some of the beta oxidation pathway substrates and through some of the enzymes involved in those pathways, we can see here the first step is an activation step, which involves placing a CoA group onto the substrate. Then there's a dehydrogenation step, which can be carried out by either ACOX-1, which is responsible for dehydrogenation of very long-chain fatty acids, of C2426, 24,6, excuse me, which is in the DHA pathway, and of dicarboxylic acids. Then there's the ACOX-2 enzyme, which is involved in dehydrogenation of prostanic acid and of the bile acids. The hydration step mostly occurs with D-bifunctional protein, but the dicarboxylic acids also use an L-bifunctional protein, and similarly for dehydrogenation. That's the second step of the bifunctional protein. And then the last step is thiolysis, which you can see the ACAA1 and the sterol protein X, complex protein X, which is also involved throughout these steps. So now we're going to move to talking about specific groups of disorders, and we're going to start with perhaps the best known group of disorders within the Zellweger group. And originally, the most severe end of the spectrum was described, and this is what we know as the classical Zellweger syndrome, the most severe end of the spectrum. But over time, as for most of our inborn errors of metabolism, as we learn more and more about these disorders, we recognize milder forms of the disorder, neonatal adrenoleukodystrophy, moving on to infantile Refsum disease. But as you all know and have seen in diagnosing these disorders, this is really not just discrete diagnoses, but more of a spectrum of severe to milder and everything in between. Let's talk about some of the classical features of the Zellweger spectrum disorders, and those really that in total are most often seen on the most severe end of the spectrum. So there's craniofacial dysmorphisms. We're going to get to those a little bit in more detail in later slides. Neuronal migration defects, leukodystrophy, and cerebral atrophy. In terms of neurodevelopmental outcomes, hypotonia, intellectual disability, lack of reflexes, and seizures can be seen. In terms of ophthalmologic phenotypes, glaucoma, cataracts, retinal dystrophy, and optic disc pallor have been described. There's deafness and impaired hearing. Certainly liver dysfunction is well represented in this group of disorders, including an enlarged liver, cholestasis, and development of cirrhosis. Renal cortical microcysts, tubular ectasia, and hydronephrosis can be seen and tend to be on the more severe spectrum of the disorder, but not always. Adrenal insufficiency, and this is a really important aspect of the disorder because this is something that can be recognized and treated and really change the outcome, some of the medical outcomes that can cause emergencies in these patients. And epiphyseal calcifications, which I'd like to talk about because this is a really interesting, unique, and striking finding, but something that needs to be caught just at the right time in diagnosis because may not be apparent later in the diagnosis. So I want to touch upon dysmorphisms in classical Zellweger disease. And again, this is as the disease moves to the milder end of the spectrum, these clinical features may be less apparent. But in an infant with classical Zellweger spectrum, what many of us often describe is a widely patent fontanelle and sutures. So if we were to draw a line here on this baby with classical Zellweger syndrome, if we were to draw a line here representing his fontanelle, it would come all the way down to the center of the forehead and all the way back. So, excuse me. So a widely painted fontanelle, a prominent high forehead. We can see here shallow orbital ridges with a low, broad nasal bridge, anteverted nares. hypertelorism. If we were to measure this, his eyes would come out as hyperteluric. We can see the epicanthal folds here. I can't show you a high arched palate, but that's also classically seen. This baby doesn't seem to be particularly micrognathic, but that's something that's also described, as well as redundant skin folds of the neck. In thinking through the differential diagnosis when we're called to see or seeing an infant in which we're considering the Zellweger spectrum disorders, included within that differential diagnosis would be neuromuscular disorders with low tone, inborn errors with hypotonia and neonatal seizures, and of course, Zellweger is an inborn error of metabolism. In terms of malformation syndromes, I just want to flip back here. So 2 syndromes that have a similar dysmorphic appearance would be considered trisomy 21 and Smith-Lemli-Opitz. And I want to step back here and just take another look at this child's face and show you that it really is, without the finding of the enlarged fontanelle, quite reminiscent of both Smith-Lemli-Opitz syndrome because of the low nasal bridge and the upturned nares, as well as potentially of trisomy 21 because of the epicanthal folds and also the low nasal bridge. So very often, these are 3 dysmorphic categories that can overlap with each other. So retinitis pigmentosa and deafness, so Usher syndrome, which would typically present later, but I have in the past actually seen a child who was diagnosed with Usher syndrome because of RP and deafness, but at age 2 or 3 began to develop some neurologic regression, and we ended up diagnosing her with a Zellweger spectrum disorder. So this is sort of a reminder that even though a child has a settled diagnosis, if something changes in their clinical presentation, we do need to reconsider what might be going on. Hepatic and GI disease. So certainly if it's an isolated liver situation, we might move away from a diagnosis of Zellweger spectrum and into a group of diagnoses that may be more specifically those of cholestasis, cirrhosis, or fatty liver. And certainly we would want to consider maybe in older patients who are developing peripheral neuropathy, but potentially they could have something along the Zellweger spectrum disorder group. So to move now towards disorders of plasmalogen biosynthesis, which are a really, really interesting group of disorders that I think we're really beginning to recognize the importance of, and further recognize the importance of the ether phospholipid group in cellular biology. The earliest described disorders of plasmalogen biosynthesis was PEX7, and I mentioned that PEX7 here is the PTS2 receptor that's responsible for bringing in 3 enzymes into the peroxisome. One of them is AGPS, which is important for peroxisome synthesis. There's isolated GNPAT deficiency, so that would be right here. Isolated AGPS deficiency. And more recently described is PEX5L deficiency. We're going to talk about that. And something I'm not going to have time to talk about is FAR1 deficiency. So we're going to talk a little bit through this pathway. So FAR1 actually is responsible for some of the synthesis of the long chain alcohols. So a deficiency in FAR1 will lead to plasmalogen biosynthetic defects, but actually a little bit of a different clinical phenotype. And we talked here about how PEX7 and PEX5 are responsible for introducing the PTS2 proteins. Eventually, AGPS and GNPA2 are responsible for producing alkyl DHAP, which is transported to the ER, and that's where ether phospholipids emerge, where their biosynthesis is complete. So defects in plasmalogen biosynthesis result in rhizomelic chondrodysplasia punctata. I apologize, I have those 2 letters flipped. So I'm going to focus on the 4 defects that lead to rhizomelic chondrodysplasia punctata. The first one we talked through already, which is PEX7 deficiency. And this causes a defect in all of the PTS2 proteins. So we mentioned thiolase deficiency, the thiolase enzyme, which again does not have a known clinical finding when it's defective because there are redundant thiolase activities in the peroxisome. Phytanyl-CoA hydroxylase, which is important for phytanic acid metabolism, and AGPS, which is important for plasmalogen biosynthesis. Then there's rhizomelic chondrodysplasia punctata 2, which is an isolated defect in GNPAT, so an isolated defect in plasmalogen synthesis. Rhizomelic chondrodysplasia punctata 3, which is an isolated enzyme defect in AGPS. And this one, more recently described, is just a fascinating molecular pathology to me. So our rhizomelic chondrodysplasia punctata type 4 was more recently described as a defect in the specific long isoform of PEX5. So as you remember, PEX5, the short isoform, is actually the receptor for PTS1 proteins. But there's a specific defect in exon 9 that actually affects only the long isoform. And it was relatively recently found that the long isoform acts as a co-receptor for PTS2 targeted proteins by PEX7 and results in an abnormal PTS2 protein import. So there's a range of clinical presentations among the rhizomelic chondrodysplasia punctatas. Classically, type 2 and type 3, which are the single enzyme defects, have that more severe classical presentation. And I'm going to move on to a slide to show you what that is. But as time has gone on, again, this is a theme I'm going to keep discussing. As we're recognizing more patients and our ability to understand both the molecular and biochemical diversity of these disorders, we're able to understand that there are milder presentations to these defects. So rhizomelic chondrodysplasia punctata type 1, again, we're recognizing over time is more heterogeneous in its clinical presentation and ranges from this classical phenotype to milder phenotypes, including rhizomelic chondrodysplasia punctata without rhizomelia, a picture of only of an isolated bony dysplasia, even isolated mild intellectual disability, and also a Refsum-like phenotype. Not surprisingly, the findings associated with rhizomelic chondrodysplasia punctata type 4, which is the more recently recognized PEX5 long isoform defect, has a similar presentation to type 1, which is, again, sort of wider spectrum of severity. So we're going to talk about the classical presentation of rhizomelic chondrodysplasia punctata, and here's a little baby who has a classical physical presentation of this condition. Dysmorphic facies are part of the classical presentation, including frontal bossing and a short nose with anteverted nares. Cleft palate can be seen, as well as cardiac malformations. Congenital cataracts are described, profound growth impairment, profound intellectual disability, and reduced survival. MRI findings may include cerebral and cerebellar atrophy, enlarged ventricles, delayed myelination, white matter signal abnormalities, as well as spinal stenosis. And just to look at some of these skeletal findings in rhizomelic chondrodysplasia punctata. So the first thing I actually want to focus on is well, first, let's go through the list. So what we can see here is metaphyseal flaring, right? So this is an abnormally flared metaphysis. But I want you to look really closely here at this little stippling here, this epiphyseal stippling. And why this is important to recognize is because this can point to a number of disorders, but it's something to recognize early because these findings can actually go away as a child becomes older. So in certain situations where we see a child who has a later diagnosis of one of these groups of disorders, we'll actually go back and pull neonatal films, if this child had neonatal films, and try to recognize, was there stippling in that period? And on occasion, we've actually gone back and looked at films that were called normal, that were interpreted as normal and actually identified stippling. So just to recognize that this is something you may have to go back and look at in earlier films. Classically, you may see a small thorax, and so this thorax here would measure small. And there's also vertebral coronal defects and vertebral coronal clefts. You can see this arrow here, which is mineralization of the intervertebral discs. There is a surprisingly wide differential diagnosis for chondrodysplasia punctata as a radiographic finding. And it is really important to work through this differential diagnosis because there are significantly different clinical implications and intellectual implications as well as family planning implications based on each of these diagnoses. So one of the classical disorders with an overlapping phenotype would be CDPX2, which is also known as Conradi-Honerman syndrome. And this is a disorder within the sterile biosynthetic pathway, as well as Child syndrome. This one is a lateral disease, so it tends to be one side of the body is affected and not others, so a little bit easier to tell the difference between this and a rhizomelic chondrodysplasia punctata. And just sort of working through the pathway, aryl sulfatase E deficiency is also on the differential. there are a couple of teratogens that can actually lead to chondrodysplasia punctata, including warfarin. And this isn't something we generally see because physicians are very aware that this is that warfarin is a teratogen. Can also be seen with alcohol exposure as well as vitamin K deficiency, which makes sense considering that's the mechanism of in the same mechanism pathway as warfarin, as well as phenytoin exposure. Multiple sulfatase deficiency can also have chondrodysplasia punctata, Quetel syndrome, which is a defect of the matrix GLA protein, mucolipidosis type 2, GM1 gangliosidosis, and galactosidosis. Hypothyroidism is reported. I haven't seen this, but it is definitely reported as a cause of chondrodysplasia punctata, as well as a multiple epiphyseal dysplasia. So I'd like to walk through a little bit how to think about individual disorders and the biochemical findings that you might see in association with those disorders. And so let's start with X-linked adrenoleukodystrophy. And we're going to talk about this disorder in much more detail sort of towards the end of the talk, but just to include it as part of walking through our biochemical diagnoses. So X-linked adrenoleukodystrophy is due to a defective import of very long-chain fatty acids, the ABCD transporter. So when you consider biochemical testing for a suspected peroxisomal disorder, say you were to test for multiple biochemical metabolites, including very long-chain fatty acids, plasmalogen, phthalic acid, pristenic acid, or bile acids, you would only see an abnormal elevation of the very long-chain fatty acids. Now, if we think about classical Zellweger spectrum disorder of the PEX5S import disorder, so the classical one, since all of the PEX5 enzymes would be abnormally imported, we would actually see a whole cohort of abnormal findings, included elevated very long-chain fatty acids, decreased plasmalogens, increased phthalic acid and pristenic acid, and abnormal levels of the bile acid precursors. But if we think about a defect in D bifunctional protein, which causes a very, very similar clinical presentation to Zellweger spectrum, you can see that enzyme defect is here. I hope you can see my arrow. Would affect everything with the exception of plasmalogen. So this is a single enzyme defect and the plasmalogen synthesis is not affected. So using biochemistry, if the clinical picture isn't clear, you can actually use the biochemistry to separate out Zellweger spectrum disorder versus the isolated D bifunctional protein deficiency. ACOX-1 deficiency, and that's the dehydrogenation enzyme here, that's responsible for dehydrogenation of dicarboxylic acids within the DHA pathway and very long-chain fatty acids, clinically can look very similar to D bifunctional protein in Zellweger spectrum disorder, but the only biochemical finding would be increased very long-chain fatty acids. And so hopefully you guys will be able to have copies of this slide, but for me, it's much easier to look at this in terms of both the biochemical findings and the pathway within the same screen to try to understand how one relates to the other. Then just to move along to the rhizomelic chondrodysplasia punctata, and I realize I flipped the D and the C in almost all of my slides, so I apologize for that. But in rhizomelic chondrodysplasia punctata type 1, which if you remember, that's an abnormal import, so this would actually be types 1 and 4, which is an abnormal import of the PTS2 proteins, and that would be either the PEX7 or the PEX5 long, you're going to have a defect both in plasmalogen synthesis, so plasmalogens are going to be down, but if you remember, the phytanyl-CoA hydroxylase is also abnormal, so phthalic acid is going to increase. And using these, this map, you can see that you can differentiate our rhizomelic chondrodysplasia punctata type 1 and 4 from 2 and 3, because 2 and 3 are isolated enzyme defects within plasmalogen synthesis, and you would only see decreased plasmalogens, but not an increase in phthalic acid. I'm also going to talk about adult Refsum disease. I think this is a really interesting disorder, and it's a defect, it's an isolated defect in phthalic acid metabolism, and you would see, not always in the infancy period, but as an individual would age, an increase in phthalic acid. So we talked a bit about the biochemical testing, which can be quite helpful which can be extremely helpful, excuse me, in terms of combining both the biochemical picture as well as the clinical features of the patient. But of course, now in the age of rapid and accurate molecular testing, molecular confirmation really is necessary, both for confirming the diagnosis as well as helping families know who are for carrier testing and for prenatal diagnoses for future offspring. Molecular diagnoses can be done via single gene, via peroxisomal panel, or peroxisomal gene panel, or via exome. Occasionally, and this is something that's less frequently used now that molecular diagnosis is so accurate and so rapid, fibroblast culture can be used to better differentiate some of the biochemical features of the patient, including getting a more accurate very long chain fatty acid content, particularly in those individuals who have a more moderate or more subtle defect. Plasmalogen synthesis, this can be important because in some patients with milder forms of rhizomelic chondrodysplasia punctata, red blood cell plasmalogen testing in and of itself might be very mild, or frankly, some of the abnormalities might be absent. And so looking at the synthesis within fibroblasts can reveal some of these biochemical defects. I can imagine a situation where the clinical picture is a little bit milder, where the plasmalogen findings are a little bit milder, and where the molecular testing may come back with variants of unknown significance. This is a test that could help sort out and really confirm a diagnosis. One can test phytanic acid oxidation as well as catalase solubility. So one of the features of peroxisomal disorders, and particularly those of the peroxisomal biogenesis disorders and a number of the other PEX disorders, is there's not really a strong phenotype-genotype correlation outside of knowing which genes are associated with rhizomelic chondrodysplasia punctata and the PTS2 receptor. So you can see here that there's a number of genes that are involved in multiple steps in peroxisomal assembly, and most of them really are associated with a spectrum of the Zellweger spectrum disorders across the spectrum. So really, it's the patient's clinical presentation that's going to tell us what that diagnosis is, not necessarily the specific PEX mutation. So let me see how I'm doing for time here. Okay, so now we're going to move on to the peroxisomal single enzyme defects. We talked about some of the biogenesis disorders. We talked about some of how to make a biochemical diagnosis, but now we're really going to hone in on a few single enzyme defects. So there's defects in beta oxidation, and I'm going to spend a good deal of time talking about X-linked adrenoleukodystrophy and AMN. We touched upon acyl-CoA oxidase deficiency as well as D-bifunctional protein deficiency. Another single enzyme defect would be 2-methyl-acyl-CoA racemase deficiency, and this involves abnormal metabolism of both pristanic acid and the bile acid intermediates. We'll talk about there's one defect in alpha oxidation, and that presents as adult Refsum disease. Catalase deficiency, we touched upon that briefly. There's not a whole lot of clinical significance to this, although it can lead to chronic aphthous ulcers, and there are some reports of this leading to some soft tissue gangrene, but in general, catalase deficiency does not present clinically symptomatic. And I will also touch upon hyperoxaluria type 1 caused by AGT deficiency. So here we are. So primary hyperoxaluria type 1 is really quite an interesting disease. So this is a peroxisomal disease that's a defect here in AGT. AGT is expressed only in liver peroxisomes, and when this is defective, when this enzyme is defective, oxalate and glyoxylate are increased, and this leads to an accumulation of oxalate and glycolate, and oxalate is what causes kidney troubles. So clinical presentations of AGT deficiency or primary hyperoxaluria type 1 or PH1 can range from mild, so occasional kidney stones, to very severe, and this can be childhood onset nephrocalcinosis and end-stage renal disease. Now, it's not entirely clear what leads to the mild versus severe phenotypes because they can be seen within the same family, within siblings with the same mutation, AGT mutations, can have a wide clinical spectrum. Diagnosis of PH1 can be suspected based on clinical features, calcium oxalate stone composition, some of the urine chemistry, so increased oxalate, increased glycerate excretion, but ultimately, because there's an overlap with PH2, PH3, dent disease, and other forms of severe oxalate overload, ultimately molecular genetic testing will help confirm your diagnosis. I put in here just to highlight enzyme activity. This is not something that's really often done because it's required enzyme activity to be done from a liver biopsy. Really, molecular genetic testing combined with the urine chemistry and the clinical findings are what's going to give you the diagnosis. So to touch upon treatment, so actually 10 to 30% of patients will respond to pyridoxine treatment, so that's an important thing to know about. There's the symptomatic treatment, something that we really all know about for managing kidney stones in general, which is high fluid intake. One may specifically try to inhibit calcium crystal formation through potassium citrate or inhibit calcium excretion by using thiazides. Ultimately, the most severe patients will go on to require a liver transplant, but really if the kidneys have already suffered damage, a liver kidney transplant is what would be necessary to resolve these aspects of the disease. So now I'm going to touch on the one known genetic defect of peroxisomal alpha oxidation, and this is adult Refsum disease. And I put a little pink X here. So this is a defect of phytonyl-CoA hydroxylase, which leads to a buildup of phytanic acid. So this is a disorder that will present typically, classically, but not always, presents in later childhood and can begin with loss of night vision and progress to a general decline in vision. And anosmia is actually often described early in the process of classical forms of this disease. Over time, additional features may present, but not always, including hearing loss, ataxia, polyneuropathy, ichthyosis, and cardiac conduction abnormalities. Interestingly, and this can be clinically striking, and I urge you to look up some of these pictures if you have time online, short metacarpals and or metatarsals can be seen in up to a third of patients, which can really be helpful in detecting this diagnosis early in the course of what might be subtle clinical findings. It's important to know that in some adults who have, milder forms of the disease, RP may be the only feature that's identified. The polyneuropathy is an interesting one. It's typically mixed, motor and sensory. It can be asymmetrical, and it will be progressive without treatment. So it's important to recognize this early. Something I really didn't know about this condition until I started looking into it is that the cardiomyopathy of this disease can be so severe that patients may require cardiac transplantation. So let's talk about how this is treated. So there's two potential aspects to treatment. The first one that must be instituted as soon as the diagnosis is made is a dietary restriction of phytanic acid. So this is a total restriction of dairy products, meats, and some fishes. And because phytanic acid accumulates in fat, this really includes the fatty fishes. So things like salmon that accumulate a lot of fat, those fish should be completely avoided. Things like shellfish that are very low fat fishes don't necessarily need to be avoided to that extent. Green leaves and veggies do not need to be restricted in these patients because our digestive mechanism does not allow us to release phytanic acid from chlorophyll. So actually it's sequestered in the chlorophyll, and green leaves and vegetables are fine. There's another mechanism to eliminate phytanic acid from the body, and that's actually lipid apheresis. As I mentioned, phytanic acid is stored in lipids, and so lipid apheresis can help reduce the body load of phytanic acid. One thing I learned as I was researching this disorder is that patients who have this disorder, who have a rapid weight loss, can actually have a Refsum disease type crisis because the phytanic acid is rapidly released from the lipids. And so that's something to warn patients who have this disorder if they're interested in losing weight or undergoing a diet. It's something that really needs to be taken with care and done slowly. So with these steps, with the restriction of phytanic acid and lipid apheresis, if instituted, will halt the progression of symptoms. There may be some recovery if things are started early enough, and that recovery tends to be in the spheres of the disease like peripheral neuropathy, ataxia, the skin findings, and cardiac abnormalities may stabilize or might improve. But in general, the retinitis pigmentosa, hearing loss, and anosmia may be less responsive. So I'm going to finish up my lecture by talking about the most common paroxysomal disorder, and that's X-linked adrenoleukodystrophy, which is something I'm sure you've all heard of at some point, if not multiple times. So X-linked adrenoleukodystrophy results from a defect in the ALDP, adrenoleukodystrophy protein, which imports the very long chain fats into the mitochondria. The very long chain fatty acids peroxisome. The very long chain fatty acids accumulate and are diverted to biosynthetic pathways that actually will then increase the very long chain fatty acids. So it's a compounding process. So ALDP is also known as the ABCD1 transporter and can result in different clinical phenotypes. The one that has an onset in childhood is the childhood cerebral form. Talk a little bit more about that, but that's the most severe early onset form of ABCD1 defects, and that occurs in a little more than a third of patients. The majority of the rest of the patients will go on to have an adult form known as adrenomyeloneuropathy, and 60% of those patients will develop cerebral demyelination. So while it's a later onset form of the disease, it is not necessarily milder in terms of clinical effects. Something that is very important to know in terms of treatment and management of the ABCD1 disorders is that adrenal insufficiency can occur in up to 65% of these individuals and must be recognized, anticipated, and managed. Something that has developed over the course, certainly, of my training and time as a biochemical geneticist is the increased recognition of the clinical effects on female carriers. For a long time, it was thought that female carriers didn't have symptoms of this disease. And as time went on, it's really been recognized that they can be quite affected. So in fact, almost 90% of women who are carriers for ABCD1 mutations can have mild AMN-like symptoms, including progressive spastic paraparesis and sensory ataxia. So it's really important to recognize these symptomatic individuals and bring them into care. These symptoms can be progressive, but in general, there's not cerebral demyelination as part of the clinical presentation. So laboratory evaluations for the ABCD1 defects. The classical diagnostic evaluation would be an increase in certain very long chain fatty acids, and that includes C26 and C24, resulting in elevated C26 to C22 and C24 to C22 ratios. Now, there can be false positives that have elevations in these same ratios in individuals who are on ketogenic diets, particularly actually if they're eating a lot of peanut products, can cause some of these things to have some of these biochemical findings. So that's important to recognize. Anyone who, as I mentioned, and I want to emphasize this again, who comes up with an ABCD1 disorder should be tested for adrenal insufficiency, because that's something that needs to be managed. And that can be done should be done via a fasting morning cortisol and an ACTH plasma test. And of course, mutation analysis of the ABCD1 gene for heterozygote detection. When you're considering testing a woman who may be a carrier for this disorder, I recommend that you test at the same time both very long chain fatty acids as well as molecular testing, because 5 to 15% of heterozygotes may have normal very long chain fatty acid levels. So detection and treatment for X-linked adrenoleukodystrophy and the other ABCD1 transporter defects. So relatively recently, these disorders have been placed on the recommended uniform screening panel, which means they are recommended to be tested in every infant in the United States. And the test for this is an elevation of C26:0 lysophosphatidyl-choline. This is a test that was developed and validated at the Kennedy Krieger Institute. And again, this is how this is screened for on newborn screen. As I mentioned, adrenal insufficiency should be tested for in all these patients and then treated as needed with glucocorticoid replacement, mineralocorticoid replacement, and androgen replacement. As part of a disorder being on the newborn screen, the reason it gets onto a newborn screen is because the natural history is understood and there's an effective treatment available that may change the natural history of the disease. And that effective treatment currently is stem cell transplantation. Over the years, there have been a number of people who have worked hard to establish guidelines in these disorders, this group of disorders, about when stem cell transplantation should occur, such that it would be effective and alter the natural history of the disease. And these guidelines really point out that the stem cell transplant should be done at the point at which MRI findings become apparent, but before clinical symptoms occur. So in order to do this, individuals who screen positive or are known to be at risk for X-linked adrenoleukodystrophy are due to undergo MRI, brain MRIs, every 6 months up to the age of 12 years to see if they're developing any of those early findings. And at that point would be recommended to undergo a hematopoietic stem cell transplant, which will halt the progression of disease. Now, this is a treatment that's not recommended once symptoms are advanced because at that point, the treatment's no longer effective. But it's important to know that there is a significant mortality risk, as high as 15% in younger kids who are being treated for X-linked adrenoleukodystrophy, and as high as 25% in adults with adrenomyeloneuropathy who are undergoing stem cell transplant. But there's been a lot of exciting advances in gene therapy for X-linked adrenoleukodystrophy, and I want to touch upon some of those exciting studies and where those stand right now. So Cartier et al. In 2009 in Science reported a really exciting gene therapy study in 2 patients at risk for X-linked adrenoleukodystrophy who had signs that they were had the MRI findings, but not yet clinical findings, meaning that they were primed, they were recommended to have stem cell transplants. But for these 2 patients, there were no matched donors. So gene therapy was initiated in these patients. So autologous CD34 cells were removed from the patients. They were administered a lentiviral vector that included a wild type ABCD1. So again, this was done ex vivo. The cells were taken out. They were transduced with a lentiviral vector with the wild type ABCD1. The patients underwent myeloablation to remove their own CD34 positive cells and infused back with their corrected cells. These patients were followed up to 30 months, and what was found that 9 to 14% of their white blood cells expressed the transduced wild-type adrenoleukodystrophy protein, ALD protein. And so what I want to show you here, this is percent of lymphocytes and monocytes expressing the protein. Before the gene therapy, there were no cells that were detected that expressed the wild type. And you can see over the course of 30 months, between 10 and 20% of these cells were shown to express the ALD protein. And let's see, and you can look here at the component of other types of white blood cells here. And as you can see, looking here at the C26, C22 fatty acids in plasma, as we mentioned, this is the one biochemical marker that can be used to detect that's abnormal in X-linked adrenoleukodystrophy. You can see prior to the stem cell gene therapy, these levels are higher. And while there is some variation, still well above the normal level, this biochemical defect is ameliorated to some extent. I'm going to show you a picture in the next slide showing that this is 1.5 years later, progressive cerebral demyelination stopped in both patients, and the outcome is comparable to that of bone marrow transplant. So let's see. So we can see here, these are patients A and B who underwent this gene therapy. And here is basically a control sample or a patient who presented with MRI findings, but did not undergo gene therapy. So this is just to see what would happen with the natural history of the disease. And you can see here this periventricular white matter abnormality that's posterior. And over the course of 24 months of not being treated, that this is really a diffuse white matter abnormality. But you can see in these patients, this patient actually started having white matter issues more anteriorly, and patient B had them more posteriorly. Looking at 12 months after the gene therapy, 16 months, 30 months after gene therapy, how significantly ameliorated this is in terms of progression compared to what would be expected during the natural history of the disease. And this is really, really quite an exciting finding. So now, 11 years later, 11 years after this was published, where are we? So there is an ongoing gene therapy trial for X-linked adrenoleukodystrophy. Just in case anybody's interested, the clinicaltrials.gov identifier is here. This study was posted on February of 2019 with the goal of enrolling, I believe it's 35 patients. And this is basically the study that I described. So autologous CD34 cells will be transduced with a lentiviral vector that contains the wild type ABCD1. The patients will undergo myeloablative conditioning and then re-administered their transduced CD34 positive cells. And I just think this is just such an exciting study, and I'm looking forward to seeing the outcomes. All right, so I've already gotten to the end of things. And I wanted to thank everybody for their time. And now I will open this to questions, and whatever I can't answer for you, I will look up for you.
Thank you so much, Dr. Vernon. That was great overview on peroxisomal disorders. I haven't gotten anything that's come through the chat in form of a question. So
That's never good.
Anybody has any, that will be okay. If not, oh, there's one that's come through.
That's good.
Hi, this is Ali, biochemical fellow at NIH. I have a question about XALD monitoring. With the frequent brain MRIs, did anybody look at the gadolinium retention? Because I imagine, are they done with contrast?
Yeah, and I'm actually not sure about gadolinium retention. That's a really interesting question, because we know that's something that had some more recent knowledge that this is something that accumulates over time. That's an interesting question, and I haven't seen that data. But if anybody else has, it would be a great time to let me know, and I will certainly look into that. That's a really good question.
A couple more have come through. So there's one that's actually anonymous, but it's a fantastic question because I think it brings up some of the complexity of newborn screening and some of the dilemmas we run into. What is the physician's responsibility, past duty to warn, when a female tests positive for XALD in a newborn screen, positive ABCD1 sequencing as well, but the family's not interested in testing a male sibling? The info regarding the proband is reported back to the state. The patient's not followed, but is there any responsibility for the sibling who's not a clinical patient of ours?
Yeah.
Great question.
That is a question that I think we need an entire ethics panel to help us answer.
Right, yes.
So, so I can tell you, I, for a while, was the chair of the Maryland State Newborn Screening Advisory Panel. And this is something we really talked about at length, actually with regard to another X-linked disorder we were considering as well, because this is a particular situation. When you diagnose one family member, you really are diagnosing a family. With XALD, the de novo rate's only 4%, so you really are diagnosing a whole family. And I don't think there is an answer that I can give you that's going to be concrete. I feel it is our duty to make sure that the family is aware of the situation, make sure that they have the information and knowledge, and really the hard stuff. They need to know the hard stuff about what could happen. And if they're not willing to hear that from us, then it's our duty to talk to their family physician, the pediatrician, to let them know what's going on. I mean, in a situation where families just really don't want to hear from us, what we'll often do is provide well-documented letters that explain everything that can happen and our contact information, and just to be very open and available and to let them know we're here to work with them, we want to help them, there's treatment for this, and to please contact us. But you know, I think if you ask 20 people, you're going to get 20 different answers on this, but it's a great question and something that you know, was a really difficult part of our discussions with how to incorporate this into the newborn screen.
Coming through also on the chat, there's a question from Paul Hillman about del-dup screening of suspected females with XALD, I'm assuming versus just ABCD1 sequencing.
Oh, I mean, I suppose that that's a good question. I think that don't know the del-dup rate on this, and that's something I should know. But there's in a situation where it's suspected in the family, we would always reflex to del-dup anyway if the sequencing is negative. I think that's kind of a no-brainer. Even in genes where I'm really suspicious and there's not been del-dup reported and we don't find anything, I'll still send for del-dup. So I think in this situation, I would also.
Good. How about from Babak Benham, is there any golden time for the ABCD1 gene therapy? And he thanks you for a great presentation.
Oh, you're welcome. So currently, I mean, you guys are asking some really, really good questions for which there's no perfect answer. So currently, the indications are similar to those for when hematopoietic stem cell transplant would occur for XALD. But I mean, it is such a good question. Like, do you transplant people pre-symptomatically? And that is something that's going to come up more and more and more as we're screening for things on the newborn screen that have both a neonatal and a later presentation, right? It's going to come up with Pompe disease, and it already does, frankly, with the enzyme replacement therapy. When do we start it? With Fabry disease as we start screening. So right now, the indications would be similar to those of again, the stem cell transplant. But I think with this, if this is proved to be successful and low risk, I think we're going to see that shift towards the asymptomatic patients to prevent any outcomes long term. But we got to wait for this trial to be over to see those successful results and then really start thinking about these questions.
Great. Janet Thomas from University of Colorado here asks, do you have much insight into XALD adult patients who go from AMN to the cerebral form of the disease? Do you offer transplant? Is it similar rate of degeneration in adults as it is in kids?
Yeah, that's a tough one. So in some individuals, it can be rapid to the point where they seem to have an AMN picture in the adults, but will then present with this rapid progression that's really just like reminiscent of the childhood ALD form. And there's just, at that point, transplant's not going to accomplish alteration of that natural history. We don't ourselves, well, Kennedy Krieger doesn't do transplants anyway, but we in our institute don't do transplantation for adults, but we do refer out these patients if they're early enough in the progression of their disease, recognizing that in adults is a 25% mortality with the transplantation. It's quite high. It's something risky, but something that we do refer out for. Mm-hmm.
And do you tend to monitor them same way you do with kids, with MRIs frequently every 6 months or so, or is it more clinical monitoring?
It's more clinical monitoring.
Okay. Carla Sargiotos asks, have you had any experience with heterozygous males or mosaics with ALD? Sorry, male mosaics with ALD or heterozygous females, I guess, who could be.
Yeah. That would be interesting. As I mentioned, because the de novo rate is only 4%, I think it would be unusual to see a mosaic male. I've never seen one, but to be fair, I can't say that I've seen enough patients that would even allow me to see that 4% of de novo. So I haven't. I mean, that would be interesting. I suppose the only way they would come to light is if they were symptomatic or flagged on a newborn screen, but that would be an interesting thing to look into.
So regarding newborn screen, I'm curious, have you guys, or have you heard of anybody around the country who's picked up an ACOX-1 patient with newborn screening, or has it just been XALD and false positives and carriers?
I haven't heard, but I am sure, I would guess they would come up. And where we are finding I could go into stories of what we're finding. We're picking up a lot of mitochondrial patients with hypocitrullinemia. I mean, there's a whole.
Yeah, please share. That's great.
Yeah.
We're going to be starting soon.
Yeah. So I imagine that we're going to start to discover all the other things that are the side products of what we're finding. Mm-hmm. There's so many metabolites where this is starting to come up. So. Mm-hmm. Yeah. We're just going to have to keep, every time you see one, report one, put it in the literature, because that's how we start understanding. I urge you to do case reports. There's a lot of utility to them. So if you start seeing these things, publish them and it'll bring them to light.
Great. There's another one. If gene therapy only restores 9 to 14% in homozygotes, how would you anticipate clinical effects in heterozygous individuals?
So remember, this is an X-linked disorder. So there's not homozygotes. Mm-hmm. And so that's just one thing I just kind of want to, I'm not sure if I made that clear enough. And there wouldn't be, I think gene therapy for heterozygous females is so way out there that I don't think it's anywhere near anybody's brain for current indications or thinking for current indications. But I mean, that's an interesting point. So, right. So if it's only restoring 9 to 14% in males who have this disease, and it is staving off the progression of the disease, then technically you don't need that much ABCD1 transporter in order to rescue the phenotype. So I imagine, as I think this person is hinting at, that this kind of gene therapy in women who are heterozygous really might not have that much of a clinical effect, because you're depending on their lionization, right? Depending on their X-linked inactivation skewing, you may really only be shifting the needle with their ABCD1 transporter a little bit, just a little bit of the time. And I imagine that might not really greatly impact the course of the disease. And I think this brings to light another thing, and something that we, again, are seeing in a number of different disorders where we now have new therapies and we're altering that natural history, that we're taking a disease and we're turning it into something else, something, arguably much milder, but other aspects of that disease are starting to come out. And I think only time is going to tell really how this affects long-term outcomes of these conditions. We looked at it a little bit earlier. We saw that this therapy does not totally normalize the very long-chain fatty acid level. So I don't know, nobody knows or can predict what's going to happen to these folks 10 years, 30 years, 40 years down the line. Is the disease going to progress or prevent or present as something different? And that's something that we have to wait and see. But that really highlights the absolute importance of the longest term possible follow-up for new therapies, to begin to understand what are we doing and what's coming next.
Good. Henry Murchowski, who asked that last question, asks if there's any sort of parallel to females with OTC in gene therapy.
Oh, yeah. But, again, I can only speak from my very limited experience. I think with female carriers for OTC, certainly in some situations, it's a no-brainer because they can be so severe. I mean, I've seen some females present just like classical males. And I think that's a bit generally an easier question, because the clinical phenotype is much more striking at a younger age in those most severely affected. But again, it's a spectrum, and it's going to be a case-by-case basis, but an interesting question.
Paul Hillman.
Fabry disease 2 is another one where you could fairly ask this question, right? Because females can certainly be affected based on their inactivation, and we have a therapy for it, and it's hard to know what and when to do it.
Mm-hmm. Paul Hillman, coming back to the del-dup analysis, would you do del-dup analysis in a male screening positive for XALD but found to have normal, very long chains and negative sequencing?
Oh, absolutely. I absolutely would, because the downside of missing something is too great. You just need to take that off the table. It's to say, I'll do that with another disorder where you get a lot of weird biochemical positives, like the long chain, like the LCAD, right? I'll send the sequencing, but I always send del-dup because I'm a neurotic person, and I'm too neurotic to miss just that del-dup mutation. I will always send it just to take it off the table.
Maria Laura Duque-Lacio is asking, can you comment on the recent Metabel discussion started by Dr. Mendelsohn about abnormal very long chains without variants identified and how to follow? That's a good question. I don't know about the chain. I haven't read the Metabel
I didn't see the chain. I saw a lot of people piping in on that one.
Right.
And we have had that situation before. I think it very, very strongly depends on the clinical phenotype. We had a situation in a child. I'm just giving you an anecdote to know that these things can be so difficult to work out, who really looked like they had a Zellweger spectrum disorder, and who had just persistently abnormal very long chains, and had liver dysfunction, and they turned out to have a CDG in the end after we did whole exome sequencing, and it was totally out of the realm of peroxisomal disorders, but totally like a phenocopy of a peroxisomal presentation. And so there's no easy answer here, just to know that the very long chains those abnormal very long chains are not normal, and there's a reason for them, but it might not be peroxisomal.
Yeah, we actually had a patient who had abnormal very long chains who had DGWOC depletion deficiency. Mitochondrial syndrome. Yeah.
That's really
so there are a lot of not false positives, but definitely not true positives for peroxisomal diseases out there.
Yeah.
Good. Anybody else? Laura's asking, so the pursuing genetic testing beyond a peroxisomal gene panel would be warranted at that point?
Oh, I would, yes, I would probably send an exome. Just to be frank, because of my experience of this child having a CDG, which I would never have a million years guessed, and it's a CDG where there's, I think, 4 or 5 cases, and there is no other way I could have diagnosed this child. And granted, she had more going on than just the very long chains, and that's why we sent the test, because there was a lot going on for her, but I would have never picked the thing that she had I not sent an exome. After I tortured myself with all the PEX genes and the fibroblast cultures and the enzyme testing and the whole thing, I was like, forget it, we're just gonna send an exome, and that's how we found it. I kind of wish we'd just done it from the beginning, but that's a whole other story.
Did you wind up doing CDG transferrin testing?
It was normal.
Normal.
I'll tell you, this is a whole other chain, but every CDG I've ever diagnosed has been on exome, not on transferrin testing. I think I have bad luck.
And I guess that kind of backs me up to what's your general clinical approach if you're suspecting this with possible phenocopies of different things? Would you, at this point, knowing what you know, would you jump right to exome, or would you dabble around with biochemical and panel testing? It's probably case-by-case basis, but
It is. I generally start, and for any of you who have been to NAMA, this is one of our debate questions that I don't know how many of you have been to NAMA and seen those debates, is there'll be the side that says, oh, should you do whole exome or should you do biochemical? But I don't think they're mutually exclusive. I'll usually start both at the same time, frankly. I'll start molecular and biochemical depending on what the situation is. So oftentimes if they look like peroxisome, I'll send the very long chains and then maybe the gene panel, or depending on if things are really bad, if the situation's really bad, I'll send the biochemistry and an exome at the same time just to get it done.
great. Anybody else? Very informative. I mean, the X-linked adrenal leukodystrophy questions, I think there's so many of them because we're just tipping the iceberg on pathophysiology, biomarkers, affected family members, and ethics. I mean, there's so much with that with newborn screening especially is being uncovered pretty quickly.
It is. We're going to learn a lot.
Yeah, I think so. Well, I think that might be it. Speak now or forever hold your peace. Anyone?
And I'm happy for my email address to, if everyone has my email, just email me with questions. It's hvernon1@jhmi.edu. I'm always available. If I don't know the answer, I can ask the people who do know the answer and get back to you.
Thank you so much. This was a great discussion, great lecture, and we really appreciate your time, Dr. Vernon. Thank you.
Take care. Bye-bye.
Bye all. Have a good weekend.
You too.